Ventilatory support. When do they need it? One of the best tools that you have is just your general assessment skills. Are they sick or are they not sick? Are they profoundly short of breath? Do they look like they're getting better or worse? Are their lips turning blue? Are they bradycardic or tachycardic? Is that from a breathing problem or is that from a cardiac problem? So some of the things to look for is that decreased LOC, or are they combative? Can they not stand having an oxygen mask on their face? Are they having trouble maintaining their respiratory effort? Are they getting tired? The cyanosis. All those things go into your decision of, do they need ventilatory support? So back to their respiratory rate. Are they getting better or worse? Are they starting to breathe faster as they become more short of breath, or are they is it starting to slow down as they are completely giving up, going into respiratory failure? Could this just be a hyperventilation scenario? So some of those tools that we can use to help us assess that are, of course, looking at their respiratory rate, oxygen saturation. You know, is their pulse ox 100%, or are they starting to desaturate? And then capnography is another powerful tool. It can provide you with a lot of information about the quality of their breathing, and that can also give you a hint between situations like, you know, are they in congestive heart failure, which is going to be one direction of treatment, compared to COPD, which is a completely different pathway. So some of the tools that we're going to use of course, your pulse ox. Some of the tools that we're going to use, in BLS, the MPA and the OPA have fallen out of favor, and there's no significant advantage to using it with a BVM. That doesn't mean that you absolutely shouldn't use it. You should still follow whatever your protocol is. However, if you can't get it to it quickly, the best outcome is going to be to go ahead and start using that BVM. And then there's also mechanical ventilators, like we carry the oscillator. If you're in a hospital setting, they may be using the actual mechanical ventilator there at the hospital. And all those tools will help with better patient outcomes than just letting them sit there and guppy breathe. So what do you need? Ideal BVM. Not every BVM is created equally. Not every BVM is proper for the patient that you have in front of you. It needs to be properly sized. Is this an adult patient? Is this a pediatric patient? Is it an infant? You're probably not going to be able to deliver the proper tidal volumes with an infant on a child, and the same way with an adult compared to a child. You're not going to have the right tidal volume if you're using a child-sized BVM on an adult. Your BVM should have a reservoir in case your patient starts breathing on your own. That way that you've already got that reservoir there for them, and you can still be assisting. The pop-off valve can help you keep from overventilating or causing damage to your patient whenever you're doing it. And another important portion of that BVM is the properly inflated mask. If you do not have a properly inflated mask, you're not going to be able to get that good seal to be able to ventilate those patients properly. So you've got your BVM. Now what do we do? Ideally, 2 people. 2 people are the best way to go ahead and deliver those breaths. It's not easy for one person to be able to get that good mask seal with one hand while ventilating with the other. That's not always feasible. It's not always possible. But if you have an extra person there that is trained and knows what they're doing, then go ahead and use them for one task or the other. That gives one person their sole focus on nothing but getting that good mask seal. So once we've got our mask seal, we're going to start delivering breaths at 10 to 12 a minute. That's about 1 ventilation every 5 to 6 seconds, and it's important to make sure that you're not over-ventilating your patient, especially in like a cardiac arrest situation, because you're increasing that interthoracic pressure. And whenever that happens, you start decreasing venous blood to the heart and decreasing cerebral and coronary perfusion pressures. And each breath should be delivered over about a second. So is it working? If it's working well, you should be able to maintain about a 90% oxygen saturation. That's not going to be with every patient. There's other factors that go into that. There may be reasons why they are not able to transfer that much oxygen. And 90% is not what your target that you're shooting for. That's just, I guess you could say, we want to be shooting for oxygen saturations higher than that. Once you start ventilating those patients, you should start seeing some differences in your CO2. You should be shooting for a range that's within normal, so that 35 to 45 millimeters of mercury. So you've got your BVM up, ventilating your patient, and you're not seeing those changes in either the oxygen saturation or your CO2. Then what do we do? One of the most important things to look at is your mask seal. That's the C and E technique that's taught in BLS. Making sure that mask seal is good. If you don't have a good mask seal, then you're just blowing off most of that air. Is their head positioned correctly? A sniffing position will open up that airway. Head tilt, chin lift, or a jaw thrust can help get that airway open. Does your mask fit properly? Do you have too big or too small of a mask? Are you getting it all the way around their nose and mouth, or is it hanging off, or are you not completely covering that area? And then you can look at some other reasons. Have they aspirated? Do they have some sort of difficult anatomy? Is your BVM working correctly? Is your pop-off valve stuck open and you're just blowing off all that air every time you try to go and give a breath? All those little things you have to look at if you're not helping your patient or improving their condition. So who are some of the people that are going to be tough? Those with trauma to the head, face, neck. Is their jaw still there? Is it still all connected? Is whenever you're getting that E on there, are you just pulling half their jaw? Is there trauma to their oro and nasopharynx? Obese patients can be a problem too. Do they have enough neck for you to be able to get them into a proper position? With your elderly patients, do they have teeth that are rattling around down their mouth, partially obstructing their airway? just take a quick look at your patient, and think about different things that could be causing that and ways that you can fix that. So we've checked all that and nothing's wrong. Now what do we do? Probably time for an advanced airway. You have several options. You can intubate them. You have combi tubes, King LTs. So endo what? What are we talking about? Endotracheal intubation. That is passing an endotracheal tube through the vocal cords to facilitate ventilation of the patient that is unable to maintain their own airway. This is a technique that started in Vietnam in the field. They had really great outcomes with it, and of course after wartime they brought it back home and found it to be teachable to people like you and me. So what do we need? Number one thing, we need a backup plan. What are we going to do if this intubation is not successful? That's where your combi tube, your King LT come into play. You also have to have your BVM ready to go. You don't want to go and start having to look for the different things that you need after you've already dropped a tube. You have your intubation kit out. You need to make sure that those ET tubes are inflating properly. And one of the most important things is a helping hand, preferably an EMT. Because we all know that us medics don't always have the best BLS skills because we rely on those EMTs a lot. So a backup plan. Why do we need a backup plan? I said I was going to intubate this patient. As much as we'd like to say that we are able to intubate every patient, whenever you're in the field, we know that things go wrong. Your patient may not be the best candidate for it. And so we have to think about ahead of time, what is our next step? So after 3 attempts of trying to get an intubation, you need to be trying something else. And you know, these other options that we have are a whole lot faster. They're not necessarily considered a definitive airway, but your combi tube, your King LT, or even just your BVM with an OPA, those are all things that are going to hopefully be able to get you by until you get to a hospital where they have, you know, a better setting, more hands to help, and possibly other tubes or other equipment like, you know, the video laryngoscopes. And those may be necessary. It's not a challenge to you personally to be able to get that person intubated. If it's not working out, it's not working out. Your BVM. Patient's head and shoulders should already be in a proper position. You need to be hyperoxygenating that patient before you make an attempt. And remember that it's good BLS skills before ALS skills. Don't get caught up in the skill and forget the patient. If you need to take a breath, so do they. So along with our equipment, it's that blue bag you should be checking every day. You should have your laryngoscope, your blade, whichever is your preference, your Mac, your Miller, your properly sized ET tube, a stylet, tube holder. If it's a cuffed ET tube, you should be having a 10 cc syringe, lube for your tube, and your suction device. So there's a couple of different kinds of blades that we carry. Of course, you have your Mac or your Miller. There's no right blade. It's whatever works best for you. Mac blades are not as good as on interior airways, and sometimes the Miller blade doesn't work well On patients with a large tongue, you don't have as much of a surface area to get that tongue scooped out of the way and keep it out of the way. And it's not about how deep you fish. Select the shortest Mac blade that is long enough. If it doesn't work, try a different one. We have a little video here.
Yeah, I just want to do a little demonstration of the mechanics of the Mac 3 versus the Mac 4 blade. When I was Nick Grimes here, I just want to do a little demonstration of the mechanics of the Mac 3 versus the Mac 4 blade. When I was trained, I was told that you were better off using a Mac 4 blade because if you needed the link that was there, if you didn't, you could just leave a little bit out of the mouth, and in that way it saved you having another go that you would need to have if the Mac 3 wasn't happening. And that made a lot of sense to me, except that I always got a better view with the Mac 3. And it took me years to work out why. But here it is. Lauren's got the Mac 4 and the Mac 3 there. She's got your right-handed Lauren. Yes. So you've got the Mac 4 in your right hand in your dominant hand, and the Mac 3 in your non-dominant hand. I'm also right-handed, so it's going to be my dominant hand versus her non-dominant hand on both sides. I'm just going to push down the tip of both blades here. And you can see that she's much more able to resist pressure on the Mac 3 than she is on the Mac 4. And the reason is, if you imagine that the laryngoscope got this long, the further away the tip gets from the handle, the harder it is to resist it. Now you're not trying to twist the blade when you do a laryngoscopy, but you are trying to resist the rotational force of the tissues pulling down the end of the blade. And that's why what I always advocate is using the shortest blade that's long enough.
Okay, just a little video explaining why. Why you want to use the shortest blade possible. So the two, most males fall into the 7.0 to 9.0 range. Most females fall in the 7.0 to 8.0 range. And pediatrics, there's an easy way to figure that out. That's you pull out your Broslow tape out of your bag that you checked to make sure it was there. Or there's a equation. The tube equals the age divided by 4, and the product of that plus 4. Some people are bigger, some are smaller. Too big of a tube may not allow it to pass through the small area between the vocal cords. And then too small of a tube can lead to the overinflation of the cuff or the gastric contents leaking out around the cuff of the tube. So you want to try to find the big enough but not too big. So you've got all your stuff together. You know that you have the right size tube. You have your BVM. You've got your backup plan. You've got your helping hand. Let's do this.
Hi, my name is Jake. I'm a paramedic intern at Pro EMS Center for Medics in Cambridge, Massachusetts. Today, with the assistance of my colleagues, I'll be demonstrating proper intubation technique. I'm going to have my assistant remove the BVM and withdraw the OPA. Laryngoscope, please. I'm opening the patient's mouth using the scissor technique, introducing the blade into the right paraglossal gutter into the valleculum, engaging the hypoepiglottic ligament. I'm going to apply bimanual laryngoscopy. I'm going to have my partner take over birth. I have a chromic Lahane grade 3 with a pogo of 10. I will change my intubation technique to use the bougie. I visualize the bougie passing through the glottic opening. Tube on. I am advancing the tube through the glottic opening. Bougie out.
Clear up the gastro. Clear left. Clear right.
We're now going to analyze our Untitled CO2 waveform. This concludes our intubation demonstration.
So with this example, they ended up using a bougie, which is a good tool to have, especially in a patient that's maybe going to be hard to intubate. I personally have gone to using a bougie pretty much all the time. I'm not saying that that's right or wrong, just something that I've done, and for one reason, to get used to the bougie and kind of become more like second nature. You did notice that everybody had a defined role that they figured out ahead of time, and everybody was ready to do their job whenever it came time to do it. Taking a break before you go ahead and intubate somebody, especially in like an RSI situation, is a really good idea. I know it's hard sometimes, especially in a stressful situation with a stressful patient, but if we're defining those roles ahead of time, it's going to make the process better, easier for us, and you're going to have better patient outcomes. So what was the bimanual stuff? Direct posterior cricoid pressure does not provide the best view, neither does burp, which is the backward, upward, rightward pressure. It's simply moving the thyroid cartilage to a position that helps you visualize the chords by the person intubating. So this is a situation where it requires two people for sure. You just basically push around until you find the correct spot that you can see the anatomy better. And once you find that, you have somebody else hold it for you while you go ahead and do that. And we have a little video here.
Bimanual laryngoscopy involves reaching around the patient's neck with your right hand and applying pressure on the thyroid cartilage. This simple and fast maneuver does two important things. First, the opposing forces of the blade tip and external manipulation drive the tip of the curved blade fully into the vallecula, causing effective epiglottis elevation. Second, it pushes the larynx backward into better alignment with the laryngoscopist's line of sight. Bimanual laryngoscopy, or ELM, is not cricoid pressure. Cricoid pressure is done by an assistant to prevent passive regurgitation of stomach contents in high-risk aspiration situations. Bimanual laryngoscopy is deliberately done to improve laryngeal view. The goal is first-pass success and avoiding episodes of bag mask ventilation. Fine movements of the blade tip at the vallecula and subtle changes in pressure and direction of force can cause dramatic differences in laryngeal exposure. Bimanual laryngoscopy is about connecting these fine movements at the anterior neck with direct observation of laryngeal view. After the view has been optimized by the laryngoscopist, an assistant can transiently maintain external manipulation at this location, freeing the laryngoscopist's right hand to place the tracheal tube.
So it's a little bit different procedure. It's not grossly different than the things that we've learned and done in the past. It's just not using one cookie cutter movement to apply to every patient. And it's not hard, and even if you have a decent view, sometimes this will be the difference between a decent view and a spectacular view. So you've gone ahead and intubated your patient, and everything seems right. How do we know that it's right? So checkpoint number 1, did you actually see the tube passing through the cords? Did you get your bougie to pass through there and then watched your tube go on through? Kind of one of the tell-alls is the Untitled CO2 or your colorimetric device. If you have an Untitled, that's what you should be using. It's not as easily tricked, we'll say, as a colorimetric device. You should be seeing good waveforms on there, although in a cardiac arrest situation they may not be perfect waveforms or like what you would see in a living patient. The next thing that you can do, auscultate the lungs and epigastrum. You shouldn't hear something that sounds like a kid blowing through his straw in his soda. If you have that, you're not in the right spot, most likely. And you should hear bilateral lung sounds. The old turkey baster is another device, and as far as I'm concerned, that's kind of fallen out of favor. If you have that and you use that, that's fine. But your Untitled CO2 is going to be the number one thing that you should go to confirm that placement, not just whenever you're intubating that patient, but continually throughout your encounter with that patient. That waveform capnography is going to be able to tell you if your tube has become displaced, and it's going to be almost immediate as compared to just checking it every so often. You should be able to, if you look at your monitor at all, you should know within a reasonable doubt very quickly whether that that patient has been extubated for some reason or another. And that's all I've got for you. That wasn't so bad, was it? So think about some of these techniques, the problems that go along with intubating somebody or ventilating somebody, and try to incorporate those thoughts into your processes and procedures that you do every day in the field.